Alright folks, so this is chapter 9, the joints. Most of this chapter is lab material, but there's a couple things I do want to point out as we go through. So we'll advance through these slides relatively quickly. I'll tell you when I'm covering it in lab, and I'll talk about the specific things that I wanted to touch in this lecture portion. Alright, so first of all, joints are called articulations, and it's two bones articulating with each other, so this is a joint. And we have different classification systems of joints, which we'll get to shortly. And here's the trade-off with joints. If you have a joint that has high degree of mobility, then it doesn't have a lot of stability. So low stability, high mobility. And then if you have a joint that has a great deal of stability, then the trade-off is it doesn't have a lot of mobility. And that's the trade-off with joints. Whoops, can't spell. So I want you to think of that as you're going through the different classification schemes of joints and the freely movable joints and how they move and what they do. So think of that. And you can see that what your text says is joint strength decreases. That's what I call the stability, as mobility increases, and vice versa. Alright, so just keep that in mind. We have functional and structural classifications of joints. The functional classifications are functional, that means how they move, and the structural classifications are what they're made of. So first of all, how they move. You can have an immovable joint, which is called synarthrotic, or a synarthrosis. You can have a slightly movable joint called an amphiarthrosis, or an amphiarthrotic joint. And you can have a freely movable joint called a diarthrotic joint, or diarthrosis. And then if we reclassify these same joints structurally, we have bony joints. And really, you're going to say, how can you have a bony joint? Well, it wasn't always a bony joint. What happened was the joint fused, and the fusion point turned into a bone. It was calcified and ossified into a bone. So the joint used to be there. And this is true for some of the bones you've been learning already. And when you learn the os coxae or coxal bone, I mean, you know that that's really three bones. That's really the ilium, ischium, and pubic bone. But they're fused, so that's a bony joint for those three fused bones. We have fibrous joints, and fibrous joints have ligaments in them. And I guess a classic example is a gomphosis with a periodontal ligament. Has periodontal ligament. That keeps your teeth in your head. Periodontal ligament. So there's ligaments in these fibrous joints. By the way, the sutures in your skull that you've been learning already, they are fibrous joints. There's sutural ligaments in there holding the different skull bones together. We have cartilaginous joints, and as you can imagine, they have cartilage in them. For example, you're going to say, well, for example, the intervertebral discs. So the intervertebral discs, the pubic symphysis, these are all cartilaginous joints. Some examples of cartilaginous joint. Believe it or not, the epiphyseal growth plate made of hyaline cartilage is a cartilaginous joint. Epiphyseal growth plate. Remember way back to chapter 6 where we talked about linear growth, how the epiphyseal growth plate, the chondroblasts make new cartilage and then the osteoblasts ossify it. Well, that epiphyseal growth plate is classified as a cartilaginous joint because it's where two bones articulate. You're going to say, well, what's articulating? The diaphysis and the epiphysis. They are articulating right there. And then the synovial joints have a synovial capsule and a synovial membrane. And all of the synovial joints are diarthrotic, freely movable, in other words. So we'll spend most of our time talking about synovial joints, but we'll cover the other ones really briefly. All right, so those are the structural classifications. Now, before I move forward, if you made me match these classifications up, they won't match up perfectly, but if you made me match them up, Here's how I would match them. I would call these two synarthrotic. I would call cartilaginous amphi, and I would call synovial di, or freely movable. So the bony and fibrous joints I would call synarthrotic. The cartilaginous joints I would call amphiarthrotic, and the synovial joints I would call diarthrotic. Now that's if you made me, because that's not a perfect one-to-one match between the functional and structural classifications. However, it's pretty darn close, meaning there's only a couple exceptions. This is where we're at, where you're going to see the exceptions right now. So what are the synarthrotic joints? Well, based on what I told you, they better be fibrous and bony, and they are fibrous and bony. However, one of the cartilaginous joints is synarthrotic. The synchondrosis of the cartilaginous joints is synarthrotic. It's immovable, and it's rib 1 to the sternum. That's what it is. So it's rib 1 to the manubrium of the sternum. You can see that right here, manubrium of the sternum. So that is a immovable joint. Now the rest of the cartilaginous joints are amphiarthrotic. So what we can see here is my two fibrous joints, sutures and gomphoses. These are synarthrotic, just like we said before. And then we said that bony joints, synostoses, are synarthrotic, immovable. But the one that should have thrown you off is the cartilaginous one, because the previous slide I said most cartilaginous joints are amphiarthrotic, and this is the one exception because I told you they weren't a one-to-one match. So there you go with the synarthrotic joints. And by the way, just so you're aware, you're going to read another text sometime in your life, and another A&P text sometime in your life, and it's going to be reclass, or the classification schemes aren't going to fit perfectly to this text if you keep it, and I highly suggest you do keep your text. And you're going to wonder why. And here's why. When you're born, the sutures are actually amphiarthrotic. You have the fontanelles. You have the soft spots in the baby's skull called fontanelles, and it's not apostrophe S. I don't know why I'm doing that. So these sutural joints are actually slightly movable when you're a newborn, but they become immovable into adulthood. The gomphoses. Well, when you have deciduous teeth, your baby teeth, your milk teeth, well, guess what? Deciduous teeth. Well, then that joint is amphiarthrotic to diarthrotic, because the tooth is going to fall out. But when you have your permanent teeth, it, of course, is a synarthrotic joint, because the only way it falls out is with an abnormal event. All right. Let's move forward. Here's my amphiarthrotic joints. You expect to see cartilaginous joints, and you do. You see my cartilaginous joints called the symphysis. All right. Well, what's the exception here? Because indeed there is. Well, one of the fibrous joints, called the syndesmosis, is slightly movable, and the syndesmosis occurs at the distal end of the radius and ulna, and at the distal end of the tibia and fibula. So both in my arm and in my leg, I have a syndesmosis. At the distal end of my radia and ulna, and at the distal end of my tibia and fibula. These are slightly movable. They don't have a lot of movement, obviously, but they have a little bit of movement there. So they are, of course, amphiarthrotic. And then my symphyses. My symphyses are my intervertebral discs and my pubic symphysis. And they're slightly movable. Think about just bending over. Your back has slight movement there. You might say, well, when is the pubic symphysis ever slightly movable? It is slightly movable, more so in women than men, and especially during pregnancy. If you're a pregnant woman, I guess you didn't mean the right woman. The sign I just wrote here means woman. Just so you guys know, this is, and I'm sure you do know, I'm sure you do. That's male. That's male. And this is female. So what I was going to write is when you are a pregnant woman, your pubic symphysis is even more movable than when you're not pregnant, because some of the hormones you release soften up this this cartilage in here. And by the way, it's fibrocartilage. That's what it is. It's fibrocartilage. Okay, lastly, with the absence of any disease of anything, these synovial joints are all diarthrotic, freely movable. That's what they are. And I can't think of any exceptions. And I'm saying in the absence of disease, because certain diseases cause them to be synarthrotic. But normally, synovial joints are diarthrotic. By the way, where we're going next is we're going to talk about the types of movement. You can move in one plane. You can move in two planes, biaxial. You can move in three planes, triaxial. So you can be monaxial. Sometimes people call it uniaxial. You can be biaxial. You can be triaxial. So we're going to talk about these movements now. But synovial joints are freely movable or diarthrotic. This is another way of looking at it. It actually lines some joints up for you and tells you about them. So it tells you about the sutures you already learned. You already learned all of these sutures right here. Of course, sutures are fibrous joints. You already learned, well, I already told you about these two syndesmoses, radial ulnar and tibiofibula. I told you about those. It's telling you there's a couple more. There's a stylohyoid and a stylomandibular. I will talk about them when I hit the muscles. So we'll talk about that joint just a little bit. And you can see that there. You can see the gomphoses. That's a tooth in your head. And then you can see another way of looking at the cartilaginous joints. Now look at, they didn't take one of these, how I want to say this. They didn't take the rib 1 to the manubrium and put it up under, oh, I see how they did it. I'm sorry. I'm thinking about this wrongly. So when you look at all of these, when you look at these fibrous joints over here in movement, you should see synarthrotic down the board, correct? Well, you don't. You get a little amphiarthrosis there. And you're going to say the squamosal suture is amphiarthrotic? Well, yeah, I'm not really sure about that. But this is saying that there's an argument for it. We already said that the syndesmoses that we talked about were slightly movable. We said that was the exception to the rule. That was one of the fibrous joints that actually was amphiarthrotic. And look at, these guys are telling you that a tooth is slightly movable, whereas I said, yeah, if it's a deciduous tooth or maybe if you have some kind of disease state, you know, some kind of periodontitis or something like that. But they're saying it's slightly movable anyway. So you can see that this is a different way of looking at it, another way of viewing it. Now I know this bothers you because you want things to be black and white. You want things to be set in stone so you know how to study them. Well, the truth is that this is a classification system and there's some give and take here and there. So that's the truth. But here's one thing that seems to always be true. Synovial joints are diarthrotic or freely movable. Having said that, let me show you a joint capsule of a synovial joint. Well, first of all, you have these hyaline cartilages at the end of the bone. They are called articular cartilages. They are hyaline cartilage. All right. And then you have the synovial membrane right here. Between the synovial membrane and the hyaline cartilage, actually just let's say synovial membrane, to keep it simple. The synovial membrane secretes the fluid into here called synovial fluid. The synovial membrane does that for us. And the hyaline cartilage gets its nutrients from the synovial fluid. And how the hyaline cartilage gets its nutrients from the synovial fluid is by moving the joint. Walking or running or jumping or doing push-ups or lifting a piece of wood or whatever you're doing. So when you move this joint, just the pressure within that fluid drives nutrients into my hyaline cartilage. So why am I telling you that? Because eventually you're going to be caring for patients that are immobilized due to their injury. And what you need to do is as quickly as possible get them on their feet. As quickly as quickly as you can safely. Get them on their feet and get them moving so that movement drives the nutrients into the hyaline cartilage. Or what's going to happen, one of several things that are going to happen from being immobilized, is their joints are going to start to break down. And that's just one of several things. That immobility is a horrible thing sometimes. So that's synovial fluid, that's the synovial joint. Synovial membrane. Notice that sometimes we have these extra pads of fluid like right there and right there and right there. These extra pads of fluid, sometimes between a tendon and a bone, sometimes between the tendon and the skin, sometimes between the bone and the skin. So there's these extra pads. These pads are called bursa. Now they're called tendon sheaths if they surround a tendon. So what I'm saying is you could have bursa that completely surround it. Now it doesn't happen to the patellar tendon, just so you know, but it completely surrounds the tendon, and it's called a tendon sheath. And that makes sense. It's a sheath around the tendon. But when they're floating pads, and I say they're floating, they're not really floating, but when they're not part of the synovial joint either, they're just some extra protection. These are called bursa. And there's a disease, of course, called bursitis, which is inflammation of your bursa. So that's the synovial joints with your tendon sheaths and sometimes bursa. All right, when you hurt your joints, you can completely dislocate your joint, and that's called a luxation. That's a complete dislocation. Or you can have a partial dislocation, and that's called a subluxation. So you can have partial or complete dislocation, luxation or subluxation. This is showing you the radius completely pulling out of the annular ligament. So the head of the radius completely pulled out of this annular ligament. One thing that does it is something like this. Usually it's not when both parents are swinging their kid. Usually when both parents are swinging their child, the child's radius doesn't luxate or subluxate because the weight of the child is divided between two arms. A lot of times this will happen when a child is swinging the entire weight of the child from one arm. So, and I've done that with my son when he was little. I mean, he's in his 20s now, but when he was little, I did that. I swung him by one arm. I shouldn't have, and I actually knew better, but didn't think it would happen to him, and I got lucky and it didn't. But you do have to be careful of that. This is the radius pulling out of the annular ligament, and that's a luxation. All right, the types of movements with these synovial joints. Why synovial joints? Because they're the ones that are freely movable. The cartilaginous joints are only slightly movable, amphiarthrotic, and the fibrous joints are synarthrotic, immovable. So when we talk about types of movements, we have to be talking about the synovial joints. We have these three types of movements. We have gliding movement, we have angular movement, which closes the angle between two bones, or I guess you could look at it as opening the angle between two bones. It depends how you're looking at the bones, really. And you have rotational movement. And we'll talk about these three types of movement: linear, angular, and rotational. And then we can say, in what axis do they move? And first of all, I want to add one here. I want to say non-axial, because there is a non-axial movement. All right. So when I talk about an axis, I'm talking about X, Y, and Z. Whoops. I wanted to draw that dotted because it means it's coming in and out of the board. Realize that it's coming in and out of the board. So here's Y, here's X, here's Z. So if you move in one of those planes, you are said to be monaxial. Some people call that uniaxial or unaxial. If you move in two of those planes, like the X and the Y plane, then you're said to be biaxial. So monaxial is only X or only Y or only Z, depending how you look at the planes. Biaxial is two of them, and then triaxial is all three of them. But there is a non-axial movement where you don't move in any of the planes. You just glide or slide. Gliding joints. They just glide or slide over each other. So that happens in your wrist, by the way. So if I were to put these axes in my wrist, one coming up and down out of my wrist, one traveling along my arm and wrist, and then it's up and down, and then one cross section. So if I had, let me just draw it here. It's gonna be easier just to draw it. Here's my fingers. 2, 3, 4, 5. All right. So if I drew an axis here, and these bones in here simply slide past one another a little bit, like up and down past one another in there a little bit, then what axis are they moving in? And there's people make arguments that they are moving in one of the axes because they're sliding along an axis or gliding along an axis. And other people make the argument that no, they're not, because they're not opening and closing that an angle in that axis. They're not doing that. So I really don't know. I mean, I don't like to argue about things like that because I don't really care. I just want to learn the different ways that we look at them and understand it so I can talk intelligently. And I hope that's all you really want to do. Or maybe someday you'll be a critic or an editor and have to write dissenting opinions of biology, and that's fine too. But some people in some textbooks make the argument that these are non-axial, that they don't move in an axis. And I've read literature that went both ways, where some people make the argument that, of course, they're monaxial because gliding is at least gliding in one axis. So I've seen it both ways. But if you ever see this word non-axial, now you know where it comes from. It's the gliding joints. All right. We already said this. A joint can't be mobile and strong. If it's high mobility, it's weak. And if it's low mobility, it can be stronger. We already said that. And then we have these joints right here. The functional classification. You need to memorize every single one of these synovial joints, the functional classification of them. And you have to know what axis they move in. Gliding is non-axial, hinge is monaxial, pivot's monaxial, condylar's biaxial. By the way, there could be an argument for triaxial on what we call a bicondylar joint. And I'll tell you which one's bicondylar. It's a weird joint. So there is that argument to be made for a bicondylar joint being triaxial. Saddle joints are biaxial, and then the only joint, and we're going to say this is the only joint that's triaxial. The only joint that's triaxial is ball and socket. Now up here I said there's an argument to be made for this, and I'm going to tell you that. As a matter of fact, it's your jaw. It's your TMJ, your temporomandibular joint. But I want to explain it and let you make your own decision. We're going to go with the book and say the only triaxial joint is ball and socket. All right, so this is showing you it's showing you linear motion. You know, it's drawing that, all right? And if you never lift the pencil from the surface, you are a gliding joint. That's what this tells you. It says you can glide all over the surface you want. If you never lift the pencil, then you are a gliding joint. Whereas, if you lift the pencil, you can see it lowering it, lifting it, lowering it to that side. Then you are an angular. Then you are a joint that has angular movement. And there's different types of angular movement. So, linear movement, angular movement, linear movement, angular movement. Circumduction is when you are triaxial. Let's just keep this simple. Circumduction is triaxial. All right. What happens is you move in all three planes, X, Y, and Z. X, Y, and Z. And it's the two ball and socket joints, your glenohumeral joint and your acetabulo-femoral joint. And how you can think of circumduction is, I'm going to tell you, it's like pointing your finger out in space and drawing a circle in space. What they're saying is you're pointing the pencil out in space and you draw a circle with a pencil. Well, you had to move back into the computer, and you had to move back out of the computer, and you had to move to the left, and you had to move to the right. So you can see you had to move every axis to do this. And this is circumduction. And this is those two joints that circumduct are the most flexible joints. Rotation, we have a couple of these in our body. Rotation is when the one bone rotates relative to another. And the classic example of that is the atlantoaxial joint between C1 and C2. Cervical 1 is called the atlas, and C2 is called the did I just get that wrong? Axis? No, I said atlanto. Did I say if I said atlanto-occipital, I didn't mean it. Okay, so I think I said atlanto. I don't. Okay, so I'm going to start again. The classic example of a rotating joint is the atlantoaxial joint between the atlas and the axis. C1 is called the atlas and C2 is called the axis. If I misspoke in the beginning of that statement and said atlanto-occipital joint, I did not mean that. It's the atlantoaxial joint. Okay, that's a rotational joint. This is one of your circumducting triaxial movements right here, the glenohumeral joint. It moves in all axes. So there's the collage for you, showing you gliding, showing you hinge, showing you condylar. It shows you why they call it condylar, because you have a cup-like depression, and then you have a little mound that fits into the cup-like depression, and you have this condylar joint right here. It gives you some examples, which you should start memorizing, because you need to know a lot of them for lab. So you give some examples right there. Notice another name for the condylar joint is ellipsoidal, so notice that. Here's the saddle joint. This is really cool. The only one I know of is the thumb. All right. So between the trapezium and the thumb, well, I shouldn't say the thumb. I should not. It's metatarsal 1. So between the trapezium and metatarsal 1, which is the metatarsal that goes to the thumb, is a saddle joint. And I can't think of another saddle joint. I think that's the only saddle joint in the body. So it's a carpometacarpal joint. It's the trapezial metacarpal 1 joint. That's what it is. That's a saddle joint. And because of that joint, we can oppose and repose our thumbs. We have opposable thumbs. Pivot joint. This is the classic example. This is the atlas, and this is the axis. And the atlas pivots around the axis. All right, so those are the collages for you. So here are some movement. Here are some movements you're going to learn in lab anyway, but let's just go through them quick. Flexions when you close the angle between two places. That's flexion. You got to be careful at the hip, because when you're flexing the hip, you're going from here to out here. You're closing the angle between the thigh and the hip. But when you flex the leg, you're closing the angle between the lower leg and the thigh. So, and I'm going to do this in lab anyway, and make sure you're careful and understand the difference between hip flexion and leg flexion, because you need to know the difference between hip flexion and leg flexion. But flexion is closing that angle. Extension is opening that angle, and then as you can see with your neck, sometimes you can normally hyperextend a joint, sometimes you can't. Obviously with the wrist, I'm hyperextending it. I can do that normally. But if you hyperextend your knee, you've just injured yourself. So some joints can be flexed, extended, and hyperextended, and some cannot be hyperextended. Abduction and adduction. Abduction is taking a part of your body away from the midline. Like think abduct a child, you take them away from their parents. If you abduct a body part, you take it away from midline, whereas adduction brings the body part back to midline. So abduction and adduction. This is pretty cool. When you open your hand like that with your fingers, that's abduction. And when you bring your fingers back together, that's adduction. This is circumduction. That's like pointing your finger out in space and making a circle. Your shoulder circumducted. So you have to be careful what you're looking at here. Whoa, I don't know what just happened there. You're looking at the shoulder right here. That's circumducting. And this is the collage showing those movements. Rotation, you can see head rotation here, and then you can see forearm rotation. Because our forearm has the ability to supinate and pronate, we can do this. We can pronate. So this medial rotation is really pronation. That's what it really is. It's really called pronation. And this lateral rotation is really supination. Now, think about what the brachium, what the humerus is doing when you're doing that. All right, because the humerus is not supinating and pronating, but the humerus is indeed rotating. See what's happening with my radius and ulna here, when I pronate, this radius comes over my ulna. So here's my radius and here's my ulna underneath it. They actually the radius crosses over the ulna. I'll show you on the skeleton in lab. But what's happening to the humerus? It's rotating. So we can't say supinate and pronate with the humerus. We have to say lateral rotation and medial rotation. But with the forearm, we can say supinate and pronate. And this is supinate and pronate. It's showing you that you roll your... Why should I find? I know this was coming. I just wouldn't have drawn it. It's showing you the radius rolling over the ulna right there. All right. This is an ankle doing inversion and eversion. If you point your sole medially, it's inversion. If you point your sole laterally, it's eversion. This is important you understand. When you pull your foot back towards your leg, it's called dorsiflexion. The muscles that do that are called extensors. I need you to realize that dorsiflexion is actually kind of an extension. And if you're in an anatomical position and you pull your hand back towards your forearm, you're actually going to tell me that's hyperextension. But the fact is that we can't supinate our foot. But this dorsiflexion is a type of extension, and in fact, the muscles that do dorsiflexion are called extensor muscles. Whereas if you point your toe, you do plantar flexion, and that's true flexion. Plantar flexion is true flexion. All right, here's the thumb doing opposition and reposition. When you pull your thumb back again to its original position, then it's doing reposition. So we have opposable thumbs. We can cross them over and say touch your pinky, say, and then reposition it. Now this TMJ joint right here, this joint does some weird things. It's a bicondylar joint. You can pull your jaw back. You can push your jaw forward. That's called retraction back and protraction forward. You can open your mouth and depress your jaw. You can close your mouth and elevate your mandible. In addition, you can do lateral excursion. Lateral excursion is when you move your mandible left to right to right to left. And I'll show you in lab. But that's called lateral excursion. So I'm going up and down, front to back, side to side. Is that not triaxial? Well, it kind of is. But we're going to go with the book and say that the only triaxial joints are the ball and socket joints. Even though this bicondylar joint is you can make an argument that it's also triaxial. All right, we're going to do some injuries to the joints, and they're going to be done because the rest is really lab. One of the big injuries is for this cartilaginous joint right here, this intervertebral joint, called a symphysis, by the way. This is called a symphysis. You can have a bulging disc. Now, what happens with this fibrocartilage, because these symphyses are fibrocartilage, I have two layers here. I have an inner nucleus pulposus, and I have an outer annulus fibrosus. That's what I have. And if my nucleus pulposus pushes against my annulus fibrosus, I have a bulging disc. All right? I could have a bulging disc. Or the entire disc might not bulge, but it could slip out of place. Maybe the entire disc slips over. Now that will actually typically lead to bulging or even herniation. But I could have a slip disc. All right? So the disc could slip over and it could lead to a bulging, and it could even lead to a herniation. Well, what's a herniation? A herniation is this right here. It's when the nucleus pulposus breaks through the annulus fibrosus. That's a herniated disc when it's breaking through. Some people call it a ruptured disc. So that's your discs. You have a bulging disc, a herniated disc, a slip disc. And by the way, just so you know, if you have a slip disc, you're most likely going to have a bulging disc, because now your disc is there's not equal pressure on all parts of your discs. Part of your disc is out in space, not really space, but there's no bone sitting on it, and the rest of your disc is holding the weight of your body, so it'll now be bulging. And then if it bulges and the annulus fibrosus is weak enough, the nucleus pulposus can bust through, and that's called a herniated disc. Okay, I'm not going to go through the details of the shoulder joint because we do that in lab. I just want to show you and remind you that there's bursa. In addition to the synovial joints, we have bursa and tendon sheaths sometimes. I didn't see a good picture of a tendon sheath, but oftentimes these bursa are wrapped around a tendon. They're called tendon sheaths. Okay, I'm not going to sit here and teach you the whole knee joint because we do that in lab. I want to show you that there are bursa in the knee joint. And the biggest thing I want to show you is the most common sports injury going. And the most common sports injury going is called the terrible triad, or O'Donoghue's triad. And what O'Donoghue's triad is the medial meniscus, the anterior cruciate ligament right here, and the medial, I already said the medial meniscus, the medial collateral ligament, the medial meniscus, and the anterior cruciate. So the terrible triad is the medial collateral, sometimes it's called the tibial collateral. It's the medial meniscus right here. This is the medial meniscus. By the way, I realized that when I said medial meniscus the first time, I circled the wrong thing. This is the medial collateral ligament right here. That's the medial collateral. Some people call it the tibial collateral. This is the medial meniscus. This is the lateral meniscus. And then the third thing, because this is 1 and 2, what's the third thing in O'Donoghue's triad? Anterior cruciate ligament. Right here, anterior cruciate ligament. These three things are most commonly injured in the knee joint. They're called the terrible triad or O'Donoghue's triad. And O'Donoghue comes from a football coach that identified the same injury over and over and over again in his players. And you can see that O'Donoghue's triad is the medial collateral, the anterior cruciate, and the medial meniscus. That's O'Donoghue's triad. All right, these tables you should start committing to memory. Now, I know it seems probably daunting and insurmountable, but if you know your bones, it's not. It really isn't if you know your bones, because you already know the bones that make up the joint. So you can pretty much guess the name of the joint, although you might get it backwards sometimes, and there's no rhyme or reason. Like, why do I say acetabulo-femoral joint? How come I don't say femoral-acetabular joint? Because I just have heard it enough times to know that it's acetabulo-femoral. And then you're going to say to me, well, maybe it's alphabetical. A comes before F. Well, tibio-talar joint is not alphabetical. Talar comes before tibio, and we say tibio-talar. I actually thought of something that might work for us. In lab, I'll tell you a rhyme and reason for naming these joints if it works. I think it does, now that it's sparking a memory. So I'll help you to memorize these joints when we get to lab. So if you know the bones, you're good to go. And you can even move the body part in yourself and probably figure out which type of movement it is. And we'll do some of these in lab as well. So these are the two tables that you're going to have to start committing to memory. These two right here. All right, old age and joints. Arthritis is the breakdown of your articular cartilage in any joint. That's arthritis. Inflammation of your joint and breakdown of the articular cartilage, the hyaline cartilage, is arthritis. But there's different types of arthritis. For example, there's osteoarthritis, which is just old age arthritis. It's just excessive wear and tear. That's what it is. But there's also an autoimmune arthritis or an immune-related arthritis, and that's called rheumatism. Well, actually, it's called rheumatoid arthritis, because rheumatism is actually something different. Wish I hadn't said that right there. Rheumatoid arthritis is when you make antibodies against your hyaline cartilage. That's rheumatoid arthritis. Well, what's rheumatism? Rheumatism is more of a syndrome of pain of the musculoskeletal system. Does it include the joints? Absolutely, it does include the joints. But it's not only the joints. And rheumatism is kind of a vague word that covers a lot of different things that may have rheumatoid arthritis involved or may not have rheumatoid arthritis involved. There might be osteoarthritis involved. So just be careful of how we use the word rheumatism. It's kind of a catch-all phrase, a little vague phrase, where if we say rheumatoid arthritis, we mean an autoimmune disease where you attack your own joints. That's what we mean. This is showing you the inflammatory condition of rheumatoid arthritis. This is because your own immune system is attacking your joints. That's what that's for right there. Gouty arthritis is to make uric acid crystals in your joints. You can get gout. I gotta tell you, I had this once. Actually, I had it more than once, but I had it once really bad. Some people get this only with certain food items, like eating liver or spleen or something like that. You know, liver of a whatever animal. Some people genetically get gout, and gout is very painful. And usually gout manifests itself the first time in your large toe. And that's actually where I got mine. It hurt to put on socks. If socks were left off because I left them off, it hurt when the breeze flowed by my big toe. Very painful. But there is some drugs out there to help treat this. Allopurinol reduces the amount of uric acid in your joints and your urine and whatever. It reduces it. So there is a drug out there to treat gout called allopurinol, and I'm sure there's other ones too. That's the only one I know. That's it, folks.